Thank you for your time as we present the University of Maryland University College Healthcare Administration Capstone Project. This is a health data analytics service product that seeks to help healthcare organizations improve outcome measures by reducing unwarranted clinical practice variability. This course on healthcare spending in the United States is saturated with commentary on the country's top nation spending status, yet less than top outcomes. Year after year, the Organization for Economic Cooperation and Development, OECD, analysis. Over 40 years ago, as a new physician, clinical practice researcher, and health policy professor, John Wimberg began investigations into unwarranted medical practice variability. He became the co-founder of the Dartmouth Institute, which combines practice variability data from throughout the U.S.
As early as the 1960s, the U.S. government has delved into efforts at cost containment through attempts at utilization review. Yet these were plagued by conflicts of interest because reviews were industry-driven. Utilization is linked, to a significant degree, to the model of reimbursement. Bundled payment models reimburse providers for a predetermined expected cost of services for a particular diagnosis. While its intent was to decrease spending while improving or maintaining the quality of care, the effects to date have been disappointing on cost reduction and inconsistent and minimal on quality improvement. The Patient Protection and Affordable Care Act established the Hospital Value-Based Payment Program, transforming reimbursement for Medicare services from quantity-based fee-for-service model to a quality-based model. Quality measures include clinical outcomes, processes, patient experience, and efficiency. The current framework by which healthcare quality is assessed is the Donavedian model, pioneered by its namesake health services physician researcher in 1966. The model categorizes quality measures into those related to outcomes, processes, and structure. Our analysis incorporates the Agency for Healthcare Research and Quality's inpatient quality indicators and patient safety indicators. Based upon hospital discharge data, this set of quality indicators is designed to be used with existing hospital administrative data.
Next, we'd like to talk about the market environment. Our service will initially target acute care hospitals. The acute care setting seems ideal for our service because hospitals have a great deal of practice variability and are also increasingly having their outcomes tracked and linked to reimbursement. Our plan is to later expand our service to other healthcare entities such as long-term care centers, inpatient rehabilitation centers, and outpatient providers. There are several barriers internal to organizations that we may face in implementing our product. The first is cost. Many organizations have some internal capability for data analysis and may be reluctant to pay a third party for additional data analysis. The second is IT infrastructure. Outcomes data will need to be provided by an organization's healthcare information technology. This means that an EMR needs to be in place. If there is not already an EMR in place, implementation can be quite expensive. However, implementation of an EMR is something that most healthcare organizations either have done or are planning to do in the very near future. Another IT issue is that outcomes data will need to be able to evolve. Outcomes data will likely be defined by the Value-Based Purchasing Program from CMS, the Hospital Consumer Assessment of Healthcare and Systems Survey, that's HCAPS, outcomes monitored by organizations such as Hospital Compare and the Dartmouth Atlas of Healthcare. As these groups change and update their quality markers and outcomes that they monitor, our service will need to keep abreast. That means that the EMR system and the health information technology system of the client organizations will need to keep up to speed and provide that data for our service. It is important to recognize that our service will face significant market competition. All healthcare information technologies collect data, and some EHR systems actually have data analytic capabilities already. Some EHR systems that do not currently have data analytics are building that into their platforms for future upgrades. In addition, there are numerous third-party healthcare data analytics vendors. Some are quite specialized, focusing on revenue cycles, targeted outcomes analysis, patient population management, and risk stratification, while others are fairly broad. Our service is intended to complement other data analytics, and it has a special usability and financial value because of its efficiency. Our system allows for especially high-yield targets for performance improvements. This is because practice variability is often an easy target that doesn't require infrastructure or additional resources. Regarding regulations, although our service will mostly be dealing with outcomes, any patient information will need to be protected. We will need to be compliant with all data security laws and regulations, which means that encryption and other data security measures will need to be employed. We will also need to be compliant with HIPAA and any other privacy laws or regulations. ICD-9 codes will need to be kept current as these are updated, and EHR incentive program updates will also need to be accommodated as these continue to develop. There is a general call in the healthcare industry for improving clinical outcomes and efficiency, spearheaded by professional organizations as well as political actors. Since our service should be useful in identifying poorly performing institutions as well as individuals, it should be embraced by these groups. We expect support from professional organizations as well as advocacy groups such as the Institute of Medicine, the Campaign for Better Healthcare, the American Medical Association, and the National Physicians Alliance. In addition, we expect support from large and influential potential clients. These include large healthcare networks such as Kaiser Permanente and MedStar Health, as well as health maintenance organizations and perhaps even other insurance companies.
As spending in healthcare is expected to increase and the industry is experiencing a market shift towards value-based purchasing, healthcare organizations could face serious consequences for not adopting standardized, efficient, and quality-driven care. Under the ACA, MACRA, CMS, and the VBP program, reimbursement and financial incentives are based on outcomes. Healthcare organizations must ensure that the delivery of care is efficient and results in positive outcomes. Healthcare organizations can measure the effectiveness of their processes by analyzing readmission rates, surgical outcomes, and mortality rates and causes. Our data analytics systems use the EHR information from healthcare organizations and compare against other healthcare databases, such as Hospital Compare and the Dartmouth Atlas of Healthcare. This enables clients to have targets for process and performance improvement strategies. These improvements will benefit all stakeholders. Our product is unique, offering an analysis that is based upon independently published outcome measures and is cross-analyzed with variability data derived from healthcare databases. Customers will have the ability to design a customized plan for intervention using their own EHR system, which will be their proprietary property. We offer a final product of targetable CPT-coded interventions with both high variability and associated suboptimal outcomes, which address relevant challenges for healthcare organizations today. Our product will be marketed through our website, highlighting the unique, customizable, and relevant nature of our data analytics systems. As a part of our marketing plan, we will ensure our product is highly ranked on internet searches, enabling a high volume of traffic on our website, along with a positive reputation for assisting organizations to adapt to the fast-changing healthcare industry.
The Agency of Healthcare Research and Quality will be our main source of funding. 3 grants awarded by AHRQ will provide funding, as well as a grant from the National Library of Medicine. These grant opportunities will allow our service to be funded for 5 years. The total amount of money received from these grants total $3,425,000. The first and second year will each total $787,500 of funding. The third year will total to $800,000. The fourth year will total to $650,000, and the fifth year will total to $400,000. Due to the time constraints of the grants, our funding will decrease each year. We project an increase in profit each year, therefore it will offset the decrease in funding. We may also have opportunities to apply for additional grants if needed. Our budget is projected out for 12 months due to the different time frames of the various grants and the potential need to reevaluate expenses. The budget includes initial one-time startup expenses, startup assets, and recurring monthly costs. The total cost of startup will be $787,500. After each consultation with a client, a detailed project plan will be drafted according to the client's needs. The cost of our service will vary depending on the specifics of each project. However, $250 an hour will be our average hourly rate. We expect the average amount of time spent on each project to be 3 months. We project our total revenue for the first year to be $360,000 and for the second year to be $480,000.